Hello viewers, me Dr. Sanjay Prasad Gupta, a consultant gynecologist. Today's topic of discussion is preventive aspects of breast cancer. Breast cancer is most common malignancy in women and it is the leading cause of death along with lung and colon cancer. Breast cancer is basically a asymptomatic disease. Late detection of breast cancer can lead to increase in morbidity and mortality. So, early detection is very important. And here comes the role of screening modalities to detect the cancer early. Optimal breast cancer screening require a individualized approach depending upon the age and risk factor along with the breast cancer density of the person and with selective use of screening modalities best suited for the woman with regard to age, breast density and risk factor. National Comprehensive Cancer Network recommends clinical encounter with average risk women, which includes clinical history, breast cancer risk assessment and clinical breast examination. Next encounter or next frequency of clinical encounter depends upon the age and risk factor assessment. Keep in mind, most of the breast cancer diagnosed in women, approximately 85%, has no identifiable risk factor. So, every woman at risk of developing breast cancer. Now, the risk factors for developing breast cancer. High risk factors are, most importantly, age above 65. Now, if the person is having genetic mutations such as BRCA1, BRCA2, P10, P53. If the person is having syndromes such as Li-Fraumeni syndrome, Coden's disease, Peutz-Jeghers syndrome, ataxia-telangiectasia, personal history of breast cancer, epithelial ovarian cancer, exocrine pancreas cancer, colon cancer, endometrial cancer. First degree relatives with 2 or more in number having early breast disease. Postmenopausal woman with breast density up to 75% or more on mammography. Atypical hyperplasia on breast biopsy. Postmenopausal increase in bone density. High degree of radiation over chest. Now, the few mild to moderate risk factors such as early menarche before 12 years of age, late menopause after 55 years of age, then nulliparity, then the woman who never breastfed, that is who are reluctant to breastfeed their child. Next, consumption of alcohol, postmenopausal obesity, less fiber diet, increase sedentary habits, that is less exercise. First full-term pregnancy after the age 30 and combined oral contraceptive use. Some studies suggest that it increases the risk of breast cancer, but most of them are uncertain about its use and breast cancer. And similarly, hormone replacement therapy, here also some studies suggest there is increased risk of breast cancer, but others says it increases the early detection of breast cancer than the increase in risk per se. Now the screening modalities. Number one is self breast examination. To know the breast disease, women should have to be breast aware. If she knows about her normal breast tissue, then she can detect any abnormality earlier and can present it to the health professional. So, self breast examination is very much required and it is done every month 7 days after menstruation in premenopausal age group, and every month on a fixed date in postmenopausal age group. Now, in the self breast examination, visualization and palpation is done. In visualization, she needs to stand up in front of the mirror and with hands up, hand by the side and hands above the waist. She should see the symmetrical, any asymmetry, any size and shape, any skin changes, any color changes, any discharge from the nipple, any other abnormality which is to be visualized. And next, palpation is also done to detect any palpable mass or any other abnormality. And it is best done while bathing and applying soap. It is done also in the supine position. Next modalities is clinical breast examination, which is done by a clinician. Here also inspection and palpation is done. In the inspection, the same thing: size, shape, position, skin changes, skin retraction, skin color, any discharge from the nipple, any other abnormality is inspected. And palpation also, it can be done by circumferential method or vertical strip method. The palpated tissue are breast tissue, axillary area, supraclavicular lymph node and infraclavicular lymph node. Next comes radiological technologies. Here comes mammography, ultrasonography and MRI. In the mammography, it can detect the mass, calcification, any abnormal area in the breast, and it can detect the masses much earlier than it is detected clinically. And mammography is best suitable for increased fatty tissue in the breast, but it is not that much suitable for dense breast and younger women. And here comes the role of digital mammography. Next is ultrasonography. Ultrasonography of the breast is also preferable in young women and in dense breast, and it can differentiate of a mass between its solid component and whether it is having any cystic component or not. And it can also aid in guidance of the biopsy of the breast mass. Now the MRI. MRI is as considered as supplementary to mammography and ultrasonography, and it is done in special cases such as in dense breast with family history of breast cancer, to detect contralateral spread of the breast cancer and lymph nodal involvement, to detect accurate local staging of breast cancer, and it is also useful in lobular breast cancer, and it is also useful in silicone implanted breast. Now, in American Cancer Society recommend annual MRI in some cases. For example, persons with BRCA mutation, persons with early breast cancer in the family, persons with a family history of BRCA mutation but untested yet, person with first degree relative of Li-Fraumeni syndrome and or Coden's disease. Now, the pathological confirmation of the breast cancer, which is done by FNAC, that is fine needle aspiration cytology. Next is core needle biopsy and excisional biopsy. In the biopsy, immunohistochemistry can also be done for ER, PR, HER2-neu and Ki67, which affects the modes of management of the breast cancer. Now, guidelines for the breast cancer screening methods. Number 1, self breast examination, which is done every month in premenopausal age group after day 7 of the menses, and at a fixed date every month in postmenopausal age group, and it is to be started as early as from the age of 20 years. Now, the clinical breast examination, it should be offered from age 25 to 39 every 1 to 3 years, and from age 40 onwards, it should be recommended annually. Now, mammography of the breast from the age 40 onwards, and it should be done annually. UPSTF recommend breast mammography from the age 50. Now, the breast screening should continue as long as the woman is healthy and expected to live 10 years or longer. Digital mammography is preferred for younger women less than 40 years of age and in women with dense breast. Ultrasonography should be added as a screening modalities in younger women and in women with dense breast. A woman whose relative has diagnosed with a breast cancer in the premenopausal age, then in that woman the annual mammography is recommended 5 years earlier to be started when her relative is diagnosed with breast cancer. MRI should be added as a screening modality in high risk individual. High risk individual is defined as including the risk factor assessment when the breast cancer risk is increases to threefold. Clinical breast examination is done in high risk individual at every 6th month interval, especially in BRCA gene carrier, because the BRCA gene carriers have very fast growing tumors. Now, the annual mammography and annual MRI is done from the age 25 in high risk individual, especially in BRCA1 carrier, and those women who select for prophylactic mastectomy support should be given. Risk reducing salpingo-oophorectomy is done at the age of 35 or as the childbearing is complete in women with BRCA1 carrier, and if they are having BRCA2 carrier, then risk reducing salpingo-oophorectomy is done at the age 40. Thanks for watching. Do subscribe my channel to view similar type of videos in future. Jai Hind.